do physical in-person shadowing. So I have probably like about a 40-minute talk with room for questions at the end. And save your questions for the end. I do talk fast, so I'm going to remind myself to slow down. All right, that's a New Yorker thing. So, day in colorectal surgery. It sounds like I'm going to talk a little bit about myself first and talk about the road to becoming a doctor, my particular path, and then go into what surgery residency was like a little bit, and then talk about fellowship and why I chose colorectal fellowship. And then go through a little bit of the differences in surgical specialties. And then lastly, I'll end with, a week in the life of a colorectal attending, and then a typical OR day, not necessarily an office day. And then I'll talk about the difference between those as well. And then some things I didn't know when I started this medicine journey, as well as some extras and some frequently asked questions that may be similar to the questions that you guys will ask. So a little bit about me first. We all wear many hats, especially as a physician, and even you guys in your day-to-day lives. I'm a physician, a teacher, a researcher, a patient advocate. Right now, I work downtown in New York City at Mount Sinai Downtown. I also operate uptown at the main Mount Sinai Hospital under the Division of Colon and Rectal Surgery in the Department of Surgery. In my spare time, I'm also a committee member for the SAGES, which is the Society of gastrointestinal and endoscopic surgeons, and the ethics and health policy committees. And then I'm also on the health equity committee and an ambassador for Fight Colorectal Cancer, which is a research and health policy group. I am a little bit of a writer, and I do write for a medical blog called Baseline Med. So this is a group of BIPOC students, pre-med like you guys, and they have started a blog that wanted to showcase the diversity in medicine. So I write for them about my experiences, and then I'm also on several other things. I have some articles on Medium, I'm on social media, and then my link tree there. And then in my spare time, I'm an artist, cat mom, a runner, a home chef, et cetera, et cetera. So I am a normal person, and if I can do this, you can totally do this. All right, so what does being a doctor mean? There's Grey's Anatomy, and then there's Grey's Anatomy. So I don't know who still watches Grey's Anatomy. I think I stopped like 10 years ago, but I think we have this vision in our minds of how awesome these people are, and I think all of us, physicians in general, are still awesome. But I think real life is a little bit different from the medical TV show. Grey's Anatomy on the right is the classic anatomy textbook, spelled differently. So how do I get there to becoming a physician of anything? So I know this is kind of like a slide here, and if you have your screen up, you might not be able to see it, but I kind of developed this when I was a resident, and I gave a talk to my alma mater at Sarah Lawrence College. And so I think I made this a hobby of explaining why exactly I have to go to medical school and residency and fellowship before I'm an attending. I don't have any other doctors in the family, so I'm definitely the first, and no one really understood that path. So, after college, you're taking the MCAT, you go to medical school, and most of them these days, there's going to be a preclinical and a clinical phase. And with the USMLE steps between them, I know that there are some changes these days with the USMLE, so you can disregard those as needed. After you graduate from medical school, you're officially a doctor, with an MD or a DO behind your name. In residency, the first year is generally called your internship. So no matter what, you're going to be an intern in your first year. You are still technically a resident, but for whatever reason, people like to say you're an intern for your first year, and then in whatever years afterwards, you're a resident. And the resident name, as you all know by now, is because people used to be called house staff, and residents usually used to actually live in-house in the hospital to take care of patients. As a surgery resident, I think the little arrows on the bottom was about all the different tests I've had to take in my lifetime. So the MCAT, the steps, and then during residency, we take an annual exam every year, the ABSITE, which is the in-service training exam, before we take our actual general surgery boards. And then after that, you do fellowship, and then in some of the subspecialties, there will be a subspecialty board. And then you become an attending, and then there's recertification exams. So the testing never ends. All right, so my path was a little bit of a winding road though. So I went to Sarah Lawrence College and I have a Bachelor of Arts in Liberal Arts. And I like to tell people that I was an art major. I wanted to be a creative writer, but also in the back of my mind, I also always thought I would eventually go to medical school. And so I did do things like anatomy and I did do chemistry and I did some of my prereqs. And I took Latin because I thought that would help with medical school. It did a little bit, but not completely. So after college, I took 3 years off. That was, the bane of my parents' existence, but I tell them 3 years was always the plan. And I actually ended up doing a lot of things in that time. I taught art, I coached volleyball, I was an EMT, and then I did some of my prereqs at a community college just to finish them. I also worked at a grocery store, and then for 3 months I traveled around Australia and Vietnam, and I volunteered at an orphanage. And it was really when I was working in that orphanage that I decided that I wanted to do a little more than be an artist and a writer. Not that those aren't amazing fields, but be able to help people in like a medicine and like healthcare kind of way. So I came back. I went to Michigan State University of College of Human Medicine. I was already in Michigan because I was coaching volleyball there. So I ended up being in-state. In-state tuition is a great thing. I got my MD after 4 years there, and I was lucky enough to match in New York City at Mount Sinai Beth Israel in their general surgery residency. And this was before we merged with Mount Sinai. And then so after residency, I did my colorectal fellowship at Stony Brook, which was also in conjunction with NYU at that point. And now I'm a colorectal attending at Mount Sinai Hospital. And this is my winding road there. But how did it start? So first I was a baby, just like all of you. And if you ask my parents, I think they'll tell you I was always a little curious, a little precocious, and I think curiosity is a must in the field of medicine. I was an immigrant. We immigrated to Canada when I was 5. So this is a picture here of my family. My grandpa, that's me in the red snowsuit because we had never seen snow before. My grandma here, that's my little sister. So I was 5 when we moved to Canada, and after that we moved to Connecticut, and then I moved back to Hong Kong, and then I moved back to the US for college. So college, this was the only picture I could find of college. This is me and my best friend. I'm on the left, your left here in the red shirt. And this is college graduation. So these are my parents. College is great. And I kind of already talked about the classes I did there in preparation for medical school. But in general, I think I had a really good experience because I explored all of my interests. And so I feel like I have kind of well-rounded background. And when patients talk to me, they want to be able to talk to a real person who has a lot of interest, who has a lot of, I don't know, things to talk about, I think. So that's what college really did for me. And there's me and my partner, almost 17 years ago? No, I don't know, something like that. All right, so medical school. So I went to Michigan State, and that's me studying. I was a little grouchy there. The point of these 2 pictures is that you will meet a lot of people in medical school, and you will become lifelong friends with them. This was at the Gold Humanism Honor Society. At the end of the year, we had to take an oath, and then this was at our match day. This was my match photo that I sent to residency programs so that they would take me. And then at the end of medical school, you get your green stripes. And I will tell you, it's an awesome feeling when you get those green stripes. So, okay, residency. So residency, there's me on the left at the start of residency, young, fresh-faced. And in the middle is our big group picture. So my residency was general surgery. And we had a class of 5 chiefs, so it's 5 people per year with a few prelim interns. I'll talk about what that means. And there's me on the right on my last day of residency. So not terribly aged, but a little more worn, I would say. All right, so a typical day in the life of a surgery resident. So surgery residency is 5 years. The first few years, you're, an intern. In most programs, you're doing more floor work and less operating. So my typical day at that time was 5 a.m., wake up, drink coffee. 5:30 a.m. Between 5:30 and 6, start rounds. And then at 6:30 a.m., usually 6:30 or 7, there would be some kind of conference, a teaching conference, or M&M, which is mortality and morbidity conference that's presented like division-wide. At 7:30 a.m., we all break, and the seniors or those of us who have cases go to the operating room or do some floor work. And floor work for an intern, I think we use the word scut, but it's, the most important thing probably in the hospital, because you're on the front lines taking care of the patient. So that includes writing notes, doing orders, discharges, social work, nutrition. If you're lucky, you can have a quick lunch. And then, somewhere between 3 and 7 p.m., you can leave work, sign out, leave the operating room. And, during my second year, a typical day really was maybe 8 p.m., 7 or 8 p.m., do laundry or dishes and have dinner and shower. And then at 9 p.m., you're going to be studying or working on research or reading and preparing for the next day. I will say this has always been true, but no matter how much you see on the floor and in real life, it's nothing like what you see on tests. So you always have to read. And then at 11 o'clock, you sleep and you start again the next day. So the typical schedule for surgery residency, at least, is 6 days a week. And so you get 1 day off a week. And that was the ACGME rule at the time of my residency. I'm hoping that they're going to actually change it a little bit more. 1 day a week, 1 day off in 7, or 2 days off in 14. So if you have a whole weekend off, it was called a golden weekend, which is just a normal weekend for everybody else. And I learned early on not to schedule anything in the evening for any day that you're on call or you're in the OR, because you will inevitably be late. But my friends and family have been very understanding, have supported me through all of this. On weekends, we did do at one point some 24-hour calls where you'll be on from 7 a.m. to 7 a.m. the next day. And in some programs, you'll also have night floats. So one team does 7 a.m. to 7 p.m. and then the second team comes in to do 7 p.m. to 7 a.m. for 1 or 2 weeks at a time. And that's pretty variable throughout the programs. But you do it because you love it and it's your calling, even though it's hard. And there's still some time for fun. So this is me with my group of chief residents. We actually had an amazing group because 4 of us chiefs were female. So 80% female surgeons, and then Dave was the one guy. This was us at a graduation dinner. There's me down there with my partner. I was a big runner up until COVID. So I did try to run in a few races a year. And then I also, why is this picture like this? This is my first loot crate, I think, Ninja Turtles. And then I took some time out for self-care. So you need to take some time for self-care. Like, absolutely don't be afraid to do that. So then fellowship. I think in some ways my fellowship was actually a little bit harder than some of my general surgery years. I ended up in Long Island. So I was driving between 2 or 3 different hospitals at a time. Sometimes I had to wake up at 4 a.m. to get to one hospital and round and then go do surgery at a different hospital. So there I am yawning. But I met, one of my best friends right now. Lisa was a fellow at a similar program, also on Long Island. And so we actually spent a lot of time comparing notes and talking to each other. And then when I graduated fellowship, the OR staff gave me a binder. So when you start your medical school, when you start your rotations, you'll see that in the operating room, each of the surgeons has their own pick list, which means that they have a list of all the instruments that they use. And I've always wondered, like, how do people find out, what they need for in the OR? And it's because these things are passed down. And then there's me with the OR nurses, who are the best nurses. And there's me at my fellowship graduation. So me and my partner, but now, what is this, since graduation, it'll be 13 years later. And then there's me with my attendings at graduation, fellowship graduation. So top tip, take some time off. It's okay to do so. After fellowship, I took 2 months off. People told me I should start work right away. And it's true, you know, I did want to keep making money, but I took 2 months off. We actually took a, you know, bucket list cruise to Alaska, which I could not do through all of residency and all of fellowship, just because, you know, it's very rare that you get, you know, the whole, you know, 2 weeks of uninterrupted time when you don't need to be studying, don't need to be worrying about anything else. So we went to Alaska, and I love animals. So there's a picture I took of a black bear, and there's a picture I took of a whale, and there's us in front of some icebergs. So attending life, this is why you want to learn about colorectal. This is my actual desk right here. It has brochures for anal warts and a pen. And this is me and my partner, Dr. Alex Kim. And on the top right here is a picture of me doing robotic surgery, but I'll show you a short video of that. And then there's me as an attending. And then in the middle here, we still have some time to see old friends, and you might notice some of these faces you've seen before in other pictures. So, you know, when you go to conferences, medicine is a small world, and surgery is an even smaller world. So you will keep seeing each other, you will keep running into each other's paths, and you make some lifelong friends for sure. A quick note about research, right? So this is me on the left, and this was a project that I did in medical school, and this is me on the right, a project that I did in my chief year. So people ask me all the time, do I have to do research? Do I have to research? The short answer is you should, but it's not completely necessary. And the easiest thing is just always do something. Like if you're involved in anything at all and you're presenting an abstract, or, you know, you have something going on, even just like a case report, it helps, because it helps you be able to present in front of people. It helps you be able to like formulate your thoughts in like an abstract, you know, table poster kind of way. And then also, of course, you know, you can put it on your resume. So for me, I have not published much. I have published, but I've done a poster or some kind of presentation every single year since, actually since before starting medical school. When I was doing my post-bac, I actually had a couple presentations there. So just be doing something. So here's the evolution. I couldn't find my medical school ID. I'm sure it's somewhere, but I have actually saved all my IDs through all the years. There's me as a resident, there's me as a fellow, and there's my ID as an attending. Which brings us to today. So there's me operating in the operating room. So why surgery? Why colorectal surgery? So you've seen this before. It's another one of these charts. There's another one that's more commonly circulated, but this one I think is a little funnier. So if you're a medical student, and then, you know, are you crazy or are you sane? Okay. So you're sane, are you hardworking? I'm gonna minimize this. It says very hardworking, and then how's your attitude? Here it says if you're mean, you should do surgery. So I kind of disagree with that, because I think that most surgeons are, you know, actually not mean, and they're very, very nice. But I also think that people kind of find their own specialty depending on what groups of people they're hanging around with. And so colorectal surgeons are a very special group, I would say. So to do colorectal surgery, you have to be able to laugh at yourself a little bit. You have to be able to, you know, not take yourself too seriously. I always take my patients seriously, but I don't know that I take myself too seriously. And that allows me to make poop jokes and butt jokes with my colleagues all day. So in surgery though, you want to help people and you want to do your best. That's a given. You know, that's why you're going, you know, that you're pre-med in college, and that's why you want to go to medical school. In surgery in particular, I wanted to come up with a few things that I thought were particularly, you know, poignant. So I think you have to be a little bit of a visual spatial thinker. So you're doing a lot with your hands, you're working with anatomy, and you have to think about how structures lie in space. You definitely have to be a problem solver. That's true for all of medicine, but once you're doing an operation, you're inside somebody's body. Despite what the textbooks say, everybody is different, and you have to be able to problem solve. You have to be comfortable with physicality. And there are actually papers written about surgeons being athletes. And I don't necessarily think you have to be like an athlete, but you have to be comfortable with moving your body, standing for long hours, sometimes even moving heavy patients from table to table. You have to be thoughtful. I actually wanted to put detail oriented at one point, but then I thought that's not always true. So you want to be detail oriented, but at the same time, be able to take a step back and see the big picture when you're looking at a patient. And so in that respect, I just put thoughtful, think about the small things, but also think about the big things. You should be confident, or at least have the potential to be confident. So I will tell you, I am pretty shy. And all through our childhood, like I didn't want to speak to anybody. I wanted to be buried in a book. And I never would have thought of myself as confident. So, but the potential to be confident, because you will be speaking a lot. You'll be speaking to your patients, you'll be speaking to your peers. And most importantly, when you're a surgeon in the operating room, you're essentially the team leader. So the entire room is looking to you for the answers. And so you definitely have to be unafraid to speak up on your patient's behalf. I do think it's always easier to speak up on another person's behalf. So maybe that's why I can do it. And then lastly, in surgery, I think one of the elements that makes us different from everybody else is we want to be the definitive answer to something. So when a patient comes to you with let's say an early stage colon cancer, surgery is the definitive answer, because you can take it out, and as long as it hasn't spread, that is the cure, right? So for early stage colon cancers. So surgery subspecialties. I get asked this a lot because I think it can be a little overwhelming. So there's general surgery, and that's my 5-year residency. And then off of that, there are fellowships. Depending on which one it is, it can be between 1 and 3 years. And the starred items have integrated programs as well, which means that you can do plastics and vascular outside of general surgery, and that can be either like a 6 or 7 year program on its own. So, but from general surgery, you can do fellowships in breast, plastics, vascular, surgical oncology, colorectal, MIS is minimally invasive surgery, or bariatrics, cardiothoracic, thoracic, and then I've actually known a few people who go into hand or head and neck. It's a little more uncommon, but you can do those things. A few of those have their own specialty boards as well. So colorectal has its own specialty board. Vascular and plastics definitely do. And so you actually have to take a second board exam after your first general surgery board exam, and then you'll be double boarded. So things that have their own path kind of outside of surgery, a general surgery path, is urology, ENT, orthopedics, neurosurgery. So those have their own programs on their own. And then when I mentioned prelim interns, so that's preliminary interns. So there are programs that take preliminary interns that are not general surgery residents, but they're an intern that just needs to do a year in general surgery before they go on to their own specialty program. And so that can include things like radiology, dermatology, anesthesia. And so the awesome thing is, when you start out as a general surgery resident, you can literally know somebody from every single one of these specialties, because they will have done, some kind of rotation, or they will have trained with you at some point. In my program, we actually spend a month on urology, and they spend a couple months on our service. So we know them pretty well too. And some of my best friends are urologists. So why colorectal? So another good question, especially when I'm doing some of my anal rectal days, and my patients will ask me, like, did you really want to be looking at butts all day? And, my answer to that is no, but there's a lot of different things that I do, and I love them all. So one of the main reasons is I wanted to be the master of the abdomen and pelvis, the master. In general surgery, we do everything. So general surgery means you literally can do head to toe, almost everything except for maybe the eyes and gynecology, but everything else we end up doing. And that's a pretty broad range. So I wanted to specialize particularly in the abdomen, in the colon, in the bowel, because I wanted to be unafraid when I encountered anything that was in the abdomen or the deep pelvis. And I've noticed that some of my attendings when I was training, like they would always be like, oh, if you put a hole in the bowel, you just put a stitch in it, or you can resect it and take it out and put it back together, and you know how to get yourself out of sticky situations, and how to get others out of sticky situations. So the other number two is there's a broad range of pathology. So there's both benign and malignant disease. I work on the colon, the rectum, and the anal rectal area, which is also called proctology, if you've ever seen that. And in some instances, small bowel too. So, and with that, that anatomy, then the range can be between diverticulitis, inflammatory bowel disease, cancer, polyps, and then like there's also the pelvic floor, which includes rectal prolapse, pelvic floor weakness, fecal incontinence, constipation, and then the actual anal stuff like hemorrhoids, fissures, fistulas. It's a pretty broad range. So, and then also I get to do big and small surgeries. So on a given, not on a given day, but I'll talk about that in a minute too. I can do big surgeries that are like open abdominal surgeries, robotic surgeries, laparoscopic surgeries, but then, on the colon and the rectum, but then I'll also be able to do smaller surgeries like on the anus, like hemorrhoids, fissures, that type of thing. And then if it's important to you, you can have a long-term relationship with your patients. So there are, I think, some surgical specialties where, well, not often, but in general surgery, if you see somebody for something like an appendix, for example, that you take care of the appendix, you see them in post-op, and you almost never have to see them again. And that's how some people prefer it. And I think I kind of wanted a relationship with my patients. So long-term relationships is important to me. With my cancer patients, with my diverticulitis patients, with my hemorrhoid patients, like I will see them again and again, over the years, and you really develop a relationship with them. And I ask them about their families and like their recent travels, and that's kind of nice. So how is colorectal surgery different from GI? I just wanted to throw that in there because I do get asked that a lot. So GI is gastroenterology, and it's a medicine subspecialty. So medicine is a separate branch. When you graduate from medical school, you can do internal medicine, and internal medicine is 3 years, plus or minus a cheap year. And at the end of that, you can do 3 years of gastroenterology. Gastroenterology tends to be more medical focused in their management. And they do a lot of colonoscopy. So all of the screening colonoscopies tend to go to GI. And, if they find something, then they send it over to us. So, and then colorectal surgery, like I said, is because it's a surgical subspecialty, we do a lot more surgical management. Not that we don't do medical management, but most of us, we're just doing the surgical side of things. So a typical week in colorectal surgery, this is literally what my week is like these days. So on Monday, I have office from 9 to 5. Most mornings I actually have a 7 a.m. conference, so I'm up before 7. And then we have tumor board at 5. In academic medicine, there's a lot of conferences. Tuesdays, I do inpatient elective cases at the main hospital. That usually starts 7:30 until whenever. You can book it until you're, you can schedule yourself until 3 or 5, but I think in general, like most of us have realized that cases will run however long they run, and don't make a dinner date after that. Wednesdays are usually more predictable for me. So office is 10 to 4 every other week. And then every other week I do ambulatory cases from 9 to 5. So ambulatory cases are those smaller cases that I talked about. So hemorrhoids, fissures, small anal polyps, fistulas, and those are more predictable. So they'll usually, take 30 minutes, 45 minutes each. And so I can have a predictable end time. On Thursdays, again, I do ambulatory cases. And then Fridays, so I either do office on the Fridays or inpatient cases that start, from 8 o'clock to whenever. Weekends, if I'm off, I'm off. If I'm on call, I'm on a call. And yeah. So a day in colorectal surgery. 7 o'clock, I'm at the hospital. I'm talking to a patient before surgery. I look at my notes and I'm in the chart. This is a 63-year-old male who saw me in the office with rectal bleeding. He has a history of anemia. He was taking a daily aspirin. He never had a colonoscopy.
His vital signs are stable right now. His abdomen is soft and non-tender. We did a digital rectal exam in the office and he didn't have any bleeding. He didn't have any recent labs at the time. So I sent him for a colonoscopy. And on colonoscopy, actually, this one I did myself. So I did a colonoscopy and we find a big mass in the right colon. So what do we do? So initially we worked him up. So the staging of colon cancer is that you do a CAT scan of the chest and then CAT scan of the abdomen and pelvis just to make sure there's no metastases to the lungs or the liver, which are the most common areas. And then we're going to check some blood work, the most important being a CEA and a CA19-9, so tumor markers. All of that being negative, they were normal, no metastases. The next step for this polypoid lesion, which was biopsied to be adenocarcinoma, by the way, is surgery. So we do a robotic. I attempt most of my surgeries robotically, at least initially. When I was in training, I actually was a non-believer in robotic surgery. However, after fellowship in my attending years, I actually think that this is a great thing for patients. They have a little less pain, a little shorter length of stay, and this has been proven in the journal articles. And it really does give the surgeon a better view and a better method of dissection. So on the top left here, you'll see the surgeons are sitting at the console. These are both men, but there's plenty of us women doing this. And then there will be one assistant standing at the bedside. And so when I do surgery, I actually initially do scrub in, and then I will put the ports in myself with an assistant, dock the robot, and then once everything is in place, the patient's under here, I go and sit at my console, and then we have a trained assistant at the bedside who can change the instruments for you. So I'm going to show a short video here. So in a right colon, you actually have to dissect out the ileocolic pedicle. And so here we have just dissected out the mesentery next to it. And this is a ligature vessel sealing device. And so here I'm actually clamping the little piece of fat that's in front of the vessel. And we burn it and it seals the fat so it doesn't bleed. And I won't show the entire thing, but next we're going to dissect behind the vessel with the instrument. So when we talk about in surgery, we're always talking about planes. And so this is the plane behind the vessel, and you can see it's distinct from the vessel itself. And I think when I was an intern, I actually did not know what this meant. And, I think I just thought everything in your abdomen was a blob that stuck together, but things have very discrete structures. And so there you are. You can actually see that the vessel sealer has gone behind the vessel, cleared out a space, and once you clamp it, you can seal it. And then so at the end of the surgery, you have, like in a robotic right hemicolectomy, you have 4 small port sites, usually 1 lower extraction site. And so this saves the patient a giant midline incision, or even, a slightly bigger, like upper midline incision. So they have less pain, like I said, shorter length of stay. It seems good to me right now. So it's 12 o'clock. I'm just finishing this operation with the robot right colon, and then a resident comes into the room with a consult. It's a 65-year-old female with some rectal bleeding. The patient's in the ER. She has a history of schizophrenia. Her bowel movements are normal, but she lives at a home, and her aide noticed something unusual. And that's what I'm looking at. So I look at this, and this is a rectal prolapse. So rectal prolapse can happen in older women, older men too. This is a particularly large one where the entire rectum has actually telescoped out of the anus. And in her case, the interesting thing was she didn't know it was there. So she had been sitting on it and kind of wiping around it without really knowing that it wasn't supposed to be there. It was big enough at this point that we did do surgery on her. And so in general, if you have a rectal prolapse that's reducible, not ischemic, as in there's no patches of gangrene that are turning black or purple, then it's safe to leave it and schedule an elective operation at a later date. However, if the patient is bleeding or uncomfortable and it's not completely reducible, as in you can't push it back into the anus, then you have to do something sooner rather than later. So in her case, we did an Altmaier, which is a perineal rectal sigmoidectomy. I call it proctosigmoidectomy, which is kind of the older term. And you essentially, what you're going to do is, or what I did, was cut around the rectal tissue. You're going to pull out the redundant portions of the sigmoid colon, and then you're going to reanastomose, so reconnect it so that it's flat at the anus. So this is the procedure on the right here. We use a lot of retractors. This is a Lone Star with some fish hooks so that we were showing the anus. And then once we've made the circumferential incision, we're pulling the entire redundant rectum out. And then once you sew the anus back in place, I actually didn't take a picture of it, but once you sew the anus back in place, it looks like a normal anus. We sometimes do what's called a levatorplasty or a suture plication in patients who also have fecal incontinence from a chronic rectal prolapse. And what this essentially does is it tightens the pelvic floor muscles around the rectum and the anus so that they're not having recurrent prolapse or fecal incontinence. So then I go home, it's like 5 o'clock, I go home and I'm having dinner and then I'm sitting in front of the TV watching TV. And then at 9 o'clock, a resident calls me and it's about an 81-year-old male with 4 days of abdominal pain and distension. His past medical history is hypertension, hyperlipidemia. He's had a right inguinal hernia repair. His labs are normal and they sent him for an x-ray and it looks like this. So this is a classic kidney bean shape, or actually it's more of a coffee bean in this case. It's a coffee bean that points towards the left hip here. So in the operating room, and this did actually happen the other night, there we made an incision. So in emergency cases, it's much more unlikely that I'll be able to do a laparoscopic or a robotic surgery in general, because it usually means that the patient has something really wrong and they're really sick. So we don't have the time to set up the laparoscopic instruments and or the robot and take a look around. The other problem is that in this particular situation, such as it's a sigmoid volvulus, the bowels are so distended that there's no room on the inside of the abdomen to actually place the robotic instrument. So all you can do is actually do the traditional old school, but very effective open surgery. So he got a cut from almost from his sternum to below his belly button. And what we found was a giant redundant loop of sigmoid colon that you see on the left there. It's purplish. It's already getting a little bit necrotic and it's a little bit sick looking. So I had to resect that out, and you can see on the right here, it was distended to almost 10 centimeters, which is quite large for a sigmoid colon. So what is sigmoid volvulus? So sigmoid volvulus is, as a person ages, most commonly the colon can become redundant and floppy. And so eventually it actually can twist around on itself and form this giant balloon. So imagine if you're making blowing up a balloon, and that motion where you have to twist it to seal the air in, that's what happens. That twist happens in the colon so that your bowel contents and the air can't go through. And then it becomes, I'm going to show you again, this giant balloon right here on the left. So in those cases, the general treatment for sigmoid volvulus is actually a colonoscopy or a flexible sigmoidoscopy first. So this is classical teaching. What they do is they would try to put a scope through of some sort and push through that twist and straighten out the colon. And then after that, leave a long red rubber rectal tube so that it continues to decompress the colon and continues to keep it straight until at a later date when we do an elective surgery. So, when we plan the surgery at a certain time after a proper bowel prep and stuff like that, it's safer for the patient, and it's more effective. However, in his particular situation, the gastroenterologist who came in to do the scope in the middle of the night actually couldn't push through this twist because it was so tight. And that does happen. It's rare, but it does happen where it's twisted so tight that we can't push through it. And so it became an emergency surgery where I had to go into the OR, untwist it. And even after untwisting it, it had been twisted for too long and the colon was too sick. So I had to take it out. So in contrast, just as a teaching point, cecal volvulus is going to be a twist in your colon on the right colon, on the right side. And so you can see a picture on the left here. This is more of the kidney bean that's pointing to your right hip, if you remember, as opposed to the coffee bean that's pointing to your left hip. So there's a comparison table on the right here. So sigmoid volvulus is a twisting of the sigmoid colon, and a cecal volvulus is a twisting of the cecum, which is the beginning of the right colon. When you see a sigmoid volvulus, it moves towards the right upper quadrant, so the right side of your belly. And then when you see a cecal volvulus, it moves towards the left side of your belly. And then the affected populations are slightly different as well. So sigmoid volvulus usually only happens in the elderly population, again, because of the redundancy in the sigmoid colon. It becomes loose and floppy and can twist on itself. And then cecal volvulus tends to be more of a young population, most likely because they were born with a floppy colon. And so a cecal volvulus is always a surgical emergency. They have to go to the operating room right away because you can't untwist that with a scope. All right, so after I did that surgery at 3 a.m., I went to bed. I had M&M conference starting at 7 a.m. and then I started seeing patients again starting at 10 a.m. the next day. And that's my hair after that. And so that's that. That was exactly 45 minutes. And then I just had a couple of other tips and tricks I'll go through, and then some FAQs and whatever questions you have for me. So people ask me about test scores. So if you score well, the extracurricular stuff will help. And if you don't score well, no matter how many extracurriculars you do, the extracurriculars won't help you. So I always say, if you're going to do this, do the things you love and make sure it shows, but also remember to study for your tests. And then, so connections. Networking is super important in the world these days. And, you know, some of us were born with connections and some of us weren't, maybe most of us weren't. I always said get by on your own merit, but be nice to everybody you meet along the way. Medicine is a small world and eventually you will run across people again. And in general, I actually, one of my favorite things was that she was our residency program coordinator, and at my residency interview, I held open the door for her and helped her put away the food. And she has always said that that's what made them take me, is that she was like, oh, this one's going to be good to people. So it's always the small things, be kind to everyone. And then classes. So as you can see, I did everything. And so you can basically do whatever you want, but you still do need to take your pre-med courses. And the sooner you do that, the better. So anatomy, biochem, statistics, whatever it is these days. But just know that you will take them again. And these things repeat and repeat in your life. So we did anatomy in college, did anatomy again in medical school. And then in residency, we have to restudy anatomy for our in-training exam. And statistics, that one keeps coming back. So ever since college, I think we've been reading papers and learning how to read papers. And it always is very, very helpful in your career. And then last but not least, there's some FAQs, but let me open it up to your questions first.
Thank you so much, Dr. Fong. That was awesome. The chat, it was just super inspiring, and thank you so much for sharing all of your advice. There were a lot of questions, so we'll get to some of the more commonly asked questions.
Yeah.
So a lot of people were asking, when you were talking about the subspecialties that you can go into after general surgery, a lot of people were asking where pediatrics and trauma surgery fit into that. So if you could talk a little bit about that.
Yes, good question. I knew I was forgetting some. Pediatric and and trauma surgery both come after general surgery. So pediatric surgery tends to be about 3 years after general surgery, and trauma depending on what type of trauma program, can be between 1 and 2 years. So some trauma programs are trauma critical care surgery after general surgery, and some are trauma critical care and acute care surgery, which is, a somewhat new model that we're dealing with these days, where general acute care surgeons will take care of everything in a hospital and essentially be like a surgical list for the hospital. So that's that model.
Great. Thank you so much for clearing that up, Chris.
Yep.
So other questions that we had after you were talking about the Altmaier surgery was how long the recovery is after that. It looked pretty intense. So some people are wondering how long people are in the hospital after that.
That's actually also a very good question. So Altmaier's, when done electively, can be a same-day surgery. I know it looks crazy, but because it's an anal rectal procedure, the stitches are right inside the anus. And so as long as the patient still keeps their bowel movements soft, they're eating, their pain is controlled, they can go home the same day. In this case, this patient actually went home the next morning. Sometimes we keep them overnight just for IV fluids and pain control, but when we do it electively, they can go home the same day.
Great, thank you so much for answering that. A lot of people are interested more about it, so thank you. Kind of switching gears a little bit more into your journey, but someone was asking if taking your prereqs at a community college later on, did it affect your medical school application in any way?
Yeah, no, and I've talked to different people, and in general, no. So I think, but in part, I did complete most of my prereqs in college. It was just I didn't have all of them. I think the few that I did in community college afterwards were biochem, and I think it was biochem and physics, actually. So I had already done most of it, but nobody ever asked me, like, why did you take these 2 classes at a community college? So yeah.
Great, that's awesome to know, because we've gotten some mixed signals about that in the past, so that's awesome.
I've heard plenty of people tell me that they did a lot of classes in community college and then transferred to college, and that doesn't make a difference either, because I think financially it actually makes more sense. So.
Yeah, we definitely do. So thank you for that. And then we have a lot of people asking just you kind of mentioned it, but how do you make a decision about like what specialty you want to go into? Because not a lot of people go into medicine just thinking I want to be a colorectal surgeon. Some people do, but not everyone goes in knowing that. So what helped you make that decision?
Yes. No, thank you for asking that. I actually think I was thinking about that. So like I said, I didn't have any doctors in the family, and so as a result, I don't know that I was particularly exposed to a lot of surgical specialties. And even when I was in medical school, I'm not sure that I knew colorectal was a subspecialty of general surgery, because we don't really talk about that in medical school. You do your 8, core rotations. And then even as a medical student, I remember thinking, oh yeah, I have some friends who are doing an ENT rotation, or they're doing a urology rotation. But if you didn't have any family members in medicine, I'm not sure I would have known, what exactly those were. So the exposure, like, I think what you guys are doing is awesome, right? So just talking about these things and getting those words out there, like knowing that these are things you can do, because I had no idea. And then I think, Baseline Med, like the blog that I do, it does a really good job too, because I don't know that people who don't have doctors in the family would have ever known. So how I decided though, was really seeing a lot of it during residency. Initially, I wanted to do plastics or breast surgery. And I love all of that. Some of my best friends are plastic surgeons, but I knew myself that I would eventually get bored, because it would be a lot of like soft tissue surgery and standing for long hours and reconstruction. And what really excited me was being inside the belly and seeing some guts and and actually being able to think about reconstructing the bowel, and that was exciting to me. And I think you'll know. So one of the things I've learned throughout the years is that you interview at a lot of different places in your life, and you're going to be going through this process where there's going to be a lot of branch points. It's going to be like medical school or no medical school, and then it's going to be like medicine or surgery, and then it's going to be like depending on what you pick there, you know, what type of medicine or what type of surgery. And each time it's going to feel like a really big decision, and it is. But I will tell you that you will make the right decision. Like, just trust your gut and go with it. And almost every time I had made a pros and cons list and then kind of threw it out the window because I went with my feeling of who I really liked when I went on the interviews. Did I like the staff? Did I meet the other applicants and I thought I would get along with them? Could I see myself there? And that feeling was more important than anything. And so I know that I know that you will fall into the group that you're supposed to fall into. And like I said, I think a lot of surgeons self-select. So colorectal surgeons, I feel like, have like a kind of laid back attitude with like a weird sense of humor. And then, you know, plastic surgeons are like super intense, but like super smart. And then, you know, breast surgeons are, I find, like super caring people. And so we're all a little bit different, and we do tend to self-select in the end.
Great. Thank you so much for sharing those little personal tidbits.
Yeah.
I have to do maybe one more question before we wrap up and then get into any FAQs that you still want to answer. So this was a perfect month to have you on, as it is Colon Cancer Awareness Month. And so there was a lot of people wondering what kind of, like, what are the risk factors for colon cancer? What should people watch out for? Like, is eating a lot of fiber really a good thing to prevent colon cancer? And just some tips on that.
I'm so glad you're asking that, because March is Colon Cancer Awareness Month. Okay, so let's start with risk factors. Let's start with actually no risk factors. So when you don't have any risk factors, you know, the regular screening age is now 45, and or 10 years before the age of the earliest diagnosis in a family member. So that people who are high risk tend to be people with first degree family members with colon cancer and or an HNPCC associated cancer. So that's Lynch syndrome. Lynch syndrome is a syndrome of associated cancers that can include endometrial, ovarian, gastric, and then there's urologic, small bowel, pancreas. So one of those associated cancers. The other things are, you know, there's a lot of literature these days, and none of which has completely borne out, but the most recent studies I've found have really thought that, you know, red meat can be slightly increasing the risk, definitely carcinogens, smoked meats with nitrates, and then things that can be protective though, perhaps probiotics and dairy products, which I thought was super interesting. But constipation. So constipation is my foe, because it will cause almost everything that is a colorectal problem. So diverticulitis, you know, is caused by chronic constipation. In some of our newer research, we're concerned that chronic constipation can cause that irritation of the colon lining and can cause, you know, eventually it erodes into some kind of dysplastic tissue and or cancer. We don't know that for sure yet, but I'm going to say avoid constipation regardless. And then obviously constipation can cause hemorrhoids and fissures and all these problems. So the symptoms though of colon cancer that you should watch out for and start screening for are if you have rectal bleeding, and I don't mean bright red blood, although it can be bright red blood, but usually like a dark tarry blood or blood mixed in with your stools, chronic abdominal cramping, pain, bloating, weight loss is actually a big one. When you go to your doctor, you should always get any of these symptoms checked out if you're having one or the other and you're concerned, but your doctor will listen to your whole constellation of symptoms, and it's usually all of these pieces together along with some diagnostic studies that will confirm the diagnosis.
Great. Thank you so much for answering that.
You're welcome.
We have questions about that, so thank you. So I guess one of the last questions that we'll ask, this has been asked repeatedly throughout the session, and it's a common question we get, is any last minute piece of advice for us, pre-meds, post-docs, going through this pre-med journey during the time of COVID?
The most important thing is be yourself and really be true to yourself. Like, it's such a long journey. It's kind of easy to lose yourself along the way. And I have to say, I probably almost did several times. One of the best tips I have is write down why you're doing this. So before you go to medical school, the night before you go to medical school, take a piece of paper on your laptop, on your phone, whatever. Write down why you're going into medicine, because I will promise you there will be times that you forget. So I did that before medical school, and then I actually did it again before residency. And when I was feeling like, this is so hard, like I've been up for 48 hours, why am I doing this? I look back at my notes and I'm like, I came into this to help people, like I wanted to make this world a better place. So just have that note, like as a reminder for yourself about why you're doing this.
Thank you.
That's all.
We love that so much. If you open up the chat, you can kind of see all the praise and all the thank yous coming in right now.
264 messages.
Yeah, that's just been throughout the whole session, but we really thank you for taking time out of your busy schedule to be here with us. We definitely learned a lot, and we know everyone here did as well.
Awesome, thank you. And you guys know how to reach me, but definitely if anyone ever has any other questions, you're always welcome to ask.
Yes, we'll go ahead and put your Instagram in the chat as well, just in case anyone wants to go give Dr. Fong a follow. Okay, it's in there.
Thank you guys so much for doing this. I think it's so cool.
Thank you. We appreciate it, and we appreciate you being here with us.
All right.
Morning.
Very good.
We'll stay in touch and we'll talk soon.
Yep.
Have a great day.
Bye.
You too. Bye-bye.